I don't want to hear.
I told him not to, by the way.
We've broken up.
Listen, we've broken up.
It's to that level.
He came out with
That's me.
That was fun.
yeah.
I was trying and I went to a tutor because the teacher that is not ready to go. I cannot play hockey. So, but the tutor is like 1 hour and 7 has to catch up.
Where do you want to sit?
That's in the you got it,
What's going to happen? They're just
Good morning. Welcome to the Department of Medicine Grand Rounds. I want you to look at this clock and tell me that I'm not in the twilight zone.
You're in the twilight zone. clock's not the same.
So depending on how you feel today, you can feel sort of static or in innovative mode and moving forward to the future. The beginning of this academic year in Grand Rounds, I spoke to you about Bailey Ashford and about Dr. Tito Acinelli. Bailey was in Puerto Rico, Tito was in Peru, and how these people had dramatically changed or had a tremendous impact in people's lives based on identifying a clinical problem, defining the cause of it based on discovery and research, designing an intervention, and then engaging with it, and having an impact not just on the few, but hundreds, and in the case of Bailey Ashford, hundreds of thousands of people. Now today was the birth, back in 1866, of somebody who has had, in my mind, an equal or larger impact, but in a very different way, through medical education. You might know that today, back in 1866, was the birth of Abraham Flexner, who very well known in Louisville. And he published a report in 1910 that was really a survey and recommendations about the quality of medical education in the 155 schools and colleges, medical schools in the United States and Canada. And that changed dramatically the way we looked at medical education. And there were two things that I wanted to highlight about his efforts. One is that he really felt strongly that students had to be exposed to patients. You can't be a doctor by just learning through lectures and reading books. That you had to be in contact with patients to become a good healer. But also importantly, that he felt strongly that students and junior faculty should be engaged in research. That was part of the medical education. It was through discovery. That if we didn't do that, 100 years from now, we would be engaged in the same type of medicine that we do today. And that was not appropriate. And for that, we have learned that there are people who engage in education and patient care and research. We have learned that there are groups that are needed to engage in big science, to engage in strong epidemiological as well as basic science research. And without those teams, we cannot move forward at the pace that we want to move forward in medical education, but also in patient care. And so today is all about that through the group from Infectious Diseases. I'm going to introduce Dr. Julio Ramirez, who's going to present our guests.
Thank you, Dr. Roman. The idea this morning is to give you an overview of this research support unit that we have in the division, but really just 2 minutes to put things in perspective. In the division, we're working with Team Wiemken, that was team that was doing the Ph.D. here in public health, and essentially we're doing clinical research with him. When he finished his Professor Louisville, he joined the division, and also we were involved then working with Rob Kelley, and Rob was at that moment a student who is doing a Ph.D. here in computer engineering, and when he finished his Ph.D. also he joined the division. Soon after, because of our educational activities and training, it became clear that because of these two guys in the division, there were a lot of people coming from outside of the division to ask for support. And then in 2012, we discussed with Dr. Roman the possibility to develop this research support unit. And then the idea today is for him and Rob to give you an overview what they've been doing, primarily what we've been doing in this support unit in the division and mostly in the Department of Medicine at the university. And with this, I let Tim and Rob to give the presentation.
Thank you. So as Dr. Ramirez mentioned, our research support units housed in the Division of Infectious Diseases, and we have our service aspects. We also offer a lot of training, and we also, as faculty members, do our own research. So we're going to focus on the services today. So if you're interested in kind of the research that we're doing or some of the trainings that we offer, go to our website at CTRSU.org, and you can view some more. So the outline of the presentation today is really going to be focused on our areas that we offer in consultation. And really, we kind of take pride in the fact that we're able to help you with your research project, really from idea all the way to publication. We really don't focus on the regulatory aspects, but there's other groups at the university we can bring you to so you can get your regulatory stuff done. So the first thing is really developing your protocol and identifying your research question. So typically this is between your mentor and yourself, or your research team and yourself, but when you're developing your research question, keep in mind these three key concepts. One, is this question relevant? Should it be answered? Because there's a lot of questions, but not all of them probably should be answered. Can it be answered? Is it some grand question that we just don't have the technology or we don't have the information to actually be able to answer yet? And do you have the resources to actually conduct this study? You might be a full-time practicing physician working 120 hours a week, and you want to conduct multi-site randomized clinical trial in 40 centers. You might not have enough time to do that. So if you don't have a mentor, you can always come to the support unit, although this is typically between your research team. We can help you kind of identify your research question a little bit better. On to the study designs. This is really a critical concept in developing your protocol. You got to have the right study design to answer your question. And in clinical research, we're usually looking at, you think about these three kind of pillars of study designs: observational studies, case reports, case series, cohort studies, case control studies, interventional studies, that prototypical clinical research design, the randomized clinical trial, and this new term, implementation studies, but it's really oftentimes quality improvement, performance improvement type of projects fall within this umbrella of implementation. In reality, there's a lot more study designs. It gets a lot more complicated very quickly. This is really just a sample of some of the other study designs that we deal with regularly in the support unit. So, just to prove that we actually have some experience with these study designs, I'm going to go through some of the people we've helped develop protocols for the designs that we've used. So, with Max Boyachi in neurosurgery, we recently submitted a protocol to the NIH looking at IV plus powdered vancomycin in the wound versus just IV vancomycin alone for prevention of surgical site infections and traumatic spine injury, primarily for MRSA. And this was really a pilot or a feasibility study. Now, feasibility studies are getting really popular now in clinical research because NIH and CDC and all these funding organizations don't want to give you millions of dollars when you might not actually be able to feasibly conduct a study. So what is feasibility? This is a little bit small, but in a feasibility study, you break down all the pieces of your study into your study components. So we have screening, recruitment, randomization, blinding, the intervention, the outcomes, all these different aspects of the research design. And for each one, you have what we call feasibility quantification. So how are you going to measure if that aspect of your research is actually feasible? So for screening, it might be the number of patients screened over a certain time period divided by the number of patients that were eligible to be screened. And in this particular study, we said anything that is 80% or greater, we're going to consider that a feasible component of the study. So once every piece of that study is determined to be feasible, we can move forward with trying to get some more money and conduct the full study. The full study being typically a randomized clinical trial. The RETO study, or the Rapid Empiric Treatment with Oseltamivir study, you've heard about before from Dr. Ramirez. It's a multi-site clinical trial we conducted here in Jefferson County. We're actually in the 4th year of this study. It's just the analysis phase. But it's in all 9 adult hospitals in Jefferson County. So it's quite a large study. We enrolled over 1,300 patients during this study. CDC funded, and it's conducting a multi-site clinical trial can be a lot more complicated than just one site, particularly when every site has a different medical record system and you have to collect a lot of patient data. Rob will talk a lot more about that. So sometimes it's really difficult to randomize a patient. So, and that might be due to, you might not have enough people to actually go out and randomize each patient. You might be concerned with some contamination effects. So if one physician is treating both a patient in the treatment arm of your study and in the control arm, you might get a little contamination or spillover effect of the treatment into the control arm. In that area, you can actually conduct a cluster randomized trial. And this is a study that was actually NIH funded to the tune of about $15 million, looking at point-of-care testing for instituting pathogen-directed therapy in patients with community-acquired disease. So here, we randomized a larger thing than just the patient, the facility. So each facility in the study was randomized to the treatment arm or the control arm, And then over time, over a 6-month period or a 1-year period, that arm crossed over to the other design, to the other arm, and we were able to move forward with that. I'll be fired without mentioning this study, collaboration between ID and Dr. Roman's laboratory. It's a prospective cohort study. We see a lot of prospective cohort studies in clinical research. So under the umbrella of this inhaled group, we have the impact of oxidative stress on HIV-induced lung disease, an NIH-funded study looking at progression of HIV and progression of COPD and lung oxidation and the redox potential of the lung. I know Dr. Roman has talked about this to you in the past. So here's our little design here. We're just enrolling patients and following them over time to see what they're doing and what their redox is and how their disease progression is. Of course, you can see on the left, our group A is HIV negative patients and COPD negative patients. So if you're a healthy individual and you want to get a BAL and a couple $100, give us a call. I was looking for people. So prospective cohort studies are great. From an observational design, that's really the ideal design for an observational study. You just don't have any intervention to do. But they're very expensive and very time consuming. So we also have retrospective cohort studies. And these are often termed like chart reviews. It's not really the ideal terminology for it, but really what we're doing is looking in charts and looking back for patient data. Our biggest retrospective cohort study is the Community Acquired Pneumonia Organization, or CAPO. Dr. Ramirez founded this in 2001. It's an international retrospective cohort study, unfunded. We have over 10,000 patients with community-acquired pneumonia in one database or another, in 130 facilities in over 30 countries. So it's a great retrospective cohort study, showing that you actually can conduct a lot of research with which is what we mostly do. So sometimes you just want to know what's happening with the patient at one point. You just want to know what's going on. So you might conduct a survey. Surveys are often considered cross-sectional studies. So this study actually, David Lord from Pediatric Psychiatry came to us asking, he said, we have all these kids with autism in the Autism Center here at UofL, and anxiety is really prevalent in autism. But we don't really know how to diagnose anxiety in these kids because it's self-report scales, and these kids with autism can't really self-report that well. So we submitted this project to the UofL Pediatric Research Foundation and we're funded. We're currently collecting data and analyzing to try to figure out if we can develop a better scale to diagnose anxiety in autistic children. And of course, the Department of Medicine is very interested in quality improvement studies, and we have decades of experience with quality improvement studies. Most recently, we've done a lot of work at Kindred across the street. If you ever had a Kindred patient, you know that there's a lot of multi-drug resistant organisms floating around. So this was looking at reduction in environmental contamination of Clostridium difficile and Acinetobacter baumannii using a quality improvement methodology and some novel disinfectant and disinfection processes. So once you've developed your study design, you say, oh, this is a perfect study. I have all the resources to conduct it. The NIH gave me $40 million. You have to be able to have the appropriate sample size. And the sample size is really a function of two things. One is the study design. So you have to know very clearly what study design you're going to conduct because the sample size calculations for each of these designs are different. The formulas are different, and there's a lot of intricacies in calculating the sample size for different study designs. And counterintuitively, you have to have a bunch of assumptions. So when you come to us, we're going to ask you for the same things. And the first thing is, what do you expect your results to be? Of course, you're like, well, why do I have to conduct a study if I already know what the results are going to be? Well, this might come from a pilot study, feasibility study. It might come from other people that have done kind of similar work, in your literature review. But we need to know what we call the effect size. And that is, what impact do you expect the treatment to have on your patients? And that allows us to calculate the minimum number of patients that you need. And if you actually find that difference in the treatment effect, then your results will be statistically significant. And of course, how much error are you willing to accept? So it's biostatistics. It's not reality, really. We're dealing with probabilities. Nothing's for sure. There's always going to be some error. It's just a matter of how much you're willing to accept. So both of these lead us to calculate our sample size. If you don't have the appropriate sample size, you probably won't get funded because the statistician reviewers and the NIH review sessions are going to know that you have a cluster randomized design and you didn't account for this and this and this. So it's really probably the most common reason that I am consulted in the support unit, and one of the most frequent all around why we're consulted. So because it's so frequent, we developed a statistical software that's freely available. If you want a copy of it, you can email me. I know a lot of you are actually probably using it at this point already, but it'll be available on the website as well soon. But it can help you calculate your sample size for simple study designs, as well as do a bunch of different biostatistical calculations for it. So now I'm going to pass over to Rob so he can talk a little bit about data management.
All right, so basically Tim went through the process of your study design, your sample size, but you have some other practical issues that you have to deal with, and that's your data that you're collecting for your study. Obviously, before you can analyze your data, you have to collect it, and this is not always a straightforward process. We have a lot of experience developing case report forms for studies ranging from very small studies to large multi-center clinical trials. We have a process that we use a lot in our group, although it may not be appropriate for every study, but typically we have a research associate who interrogates the EMR and abstracts data from the EMR and puts it into a paper case report form. And at first blush, that sounds like that's kind of an old-fashioned way to do things. Why can't we just do it electronically? But you'll see later that that actually plays into our data quality process. So as far as the case report form and getting your data collected, we can assist you with a lot of different things. We can help you develop your case report form. We can help you develop your data dictionary with appropriate coding levels. If you don't get your coding levels all straightened out before you analyze the data, your statistician, or if you're analyzing the data yourself, you'll have difficulty doing that at the end. We'll also help you put a data collection manual together with all of your study definitions. If you're running a small study and it's only a couple of people working on it, this may not be necessary, but if you're doing a large multi-site clinical trial, you need to have a data collection manual that explains all your study definitions so everybody is on the same page and all that. We can also help you with developing an electronic CRF that's equivalent to your paper CRF, because eventually you need to get this into an electronic system so that you can analyze it. And we can also help you come up with an efficient process for collecting your data, especially when you have a larger trial and you have issues of trying to coordinate with several people to get to several hospitals. In addition to that, we can help you develop tools to monitor your enrollment process. For instance, we put together a tool for a couple of large studies that we're doing right now to allow us to see what our enrollment numbers are day by day. So this is real time. Every morning, our research associates enter this data on the number of patients that have been that are eligible and enrolled into our studies. And then we have a dashboard that any of the PIs or anybody on the project really can look to find out where we are with enrollment. So we can help develop tools like that and do something like that. In addition to data collection, though, we can help you with the actual database development. So really, your study database is critical because it's your initial product of your research. Now we know your end product is going to be a manuscript, and then eventually use those manuscripts to try to get more grants. But initially, everything that you're going to collect is going to go in your database. And we have a lot of experience with many different tools to store your data. Access is one that some of you may be familiar with. SQL Server and MySQL are two others that we work with quite a bit. But the tool that we use for more than 90% of our studies now is REDCap, which some of you may already be familiar with. If you're not, REDCap was designed originally at Vanderbilt. It was originally funded with the CTSA. Once they got that to a usable product, they released it so other universities and nonprofit research institutions could use it. And it's also available to commercial organizations as well. They have to pay for it. Just to give you some stats on REDCap, right now it's being used, according to their website, just from Monday of this week, over 1,200 active institutions in 87 countries, 137,000 projects, and 186,000 users. So it's got quite a bit of market penetration in the research community. The CTRSU actually operates 4 REDCap instances in the REDCap parlance, they call them instances. The first instance is for our community-acquired pneumonia organization, which Tim mentioned earlier, and some of you may have heard about in the past. Currently, we're in the process of moving our data from our old database system to this instance. Right now, we have about 30 active cases in there, but we have another 9,000 or 10,000 that will be moving from our old database in a few weeks, actually. In addition to that, we have our CTRSU biorepository database. So I'll put a plug for our biorepository. If you happen to be interested in doing any kind of clinical study where you're going to collect samples and like to store those in the biorepository, you can contact us and we can assist with that. Right now, our biorepository currently has about 16,000, actually almost 17,000 samples in it. So we use REDCap to store the sample data, so we have a easy database to look at there. The Global Health Initiative, again, we presented this in grand rounds before, but specifically in the Global Health Initiative, we have the Refugee Health Program. And in Kentucky, or actually anywhere in the United States, when refugees are resettled in the United States, they have to have a health screening. We actually do some of those health screenings in the 550 clinic, and there are other clinics in the state that do that. But our group is the central data collection group for the entire state. So all of the refugee health data is stored here, and we have a special server set up just for that. And then finally, we have what we call our CTRSU Consultation Server, and that's essentially where all of our other projects go. So if you consult with us and say, look, I want to do a study and I need to, a database to store our data, this is where it will live. Unless you have a really large data set that you're going to be collecting, and you may actually spin up a new instance specifically for your project. Also, all of our instances are secured, usernames, passwords, and encryption of PHI. Something that Vanderbilt obviously was really concerned with when they first built this, so it's very secure. We've developed databases in several collaborations across the university, ID obviously, but also cardiovascular medicine, pulmonary, the School of Nursing, Department of Surgery, Global Health Initiative, and the Department of Pediatrics. We have also worked with several collaborations outside of UofL with databases together, including Peterson Healthcare, Kentucky One, Kindred, Kentucky Refugee Ministries, the Central American Caribbean Federation of Immunology and Thoracic Surgery, and also the AMC here in Louisville. So to give you a few more specifics about where we stand, we currently have 43 active databases across all of our REDCap instances. That represents about 2 gigs of data, which doesn't sound like that much, especially if you ever deal with genomics data and that kind of thing. But for raw clinical data, that's actually quite a bit. Might be better to take a look at the fact that we have over 30,000 records or subjects across all those databases and over 9,000 variables that we're collecting. So REDCap is quickly becoming a standard technology for clinical studies, and we have a lot of experience using it. We'll get you up and running very quickly with it. We can either teach you how to build your own databases, or we can do it for you. In fact, we really think that REDCap is going to become sort of the de facto standard. A couple of weeks ago, our group was at the CDC. We're participating in a pandemic preparedness project with several other hospitals across the universities across the country. And REDCap is actually required as part of this project. Every site has to have its own REDCap, and the central data collection group is also going to have a REDCap that all that data will flow through. So a lot of experience here, and we can help you with your data. In addition to putting your database together, we can also help you develop your data quality process. So your data quality is really a critical aspect of clinical research. There's a lot of definitions of data quality. If you look at the literature, one is measure of agreement between the information system and the real world, fitness for use, accuracy. But really, we boil it down to the golden rule of data, and that is garbage in, garbage out. All right, so you really have to manage your data quality process to make sure the data that comes out at the end is usable so that you can do your analysis. So our group can help you develop your data quality plan to make sure that you have standard operating procedures for entering data in your database, a documented data dictionary with a list of your variables that are required and that are optional, enumeration of all the validation checks for every variable collected in your study. All these things really need to be documented and decided beforehand so that as you're collecting data, you're getting exactly what you need in the format that you need. We've developed a standard process for managing data quality, sort of baked into our standard workflow when we do a study. As I mentioned earlier, we typically have a research associate who looks at the EMR, abstracts data out, puts it into a case report form. That really kicks off the first stage, or actually sort of a pre-stage of our data quality process. And we would help you, identify how this would work for your particular study. But I'll kind of walk through the stages that we use just so you can get a general idea. In the first stage, we have a research associate, a different research associate from the one who originally put the data into the paper CRF, who enters the data into the electronic system, and that is our first stage of data quality, because if that person notices any errors or inconsistencies, then he or she will get with the original research associate and they'll discuss it and see if they can figure out where the missing data are or what the problem is and resolve it. And once that is done, the system itself, in our second stage, so REDCap itself actually has validation built into it. So, for instance, let's say a typical adult human weighs between 45 and 200K. The system will automatically verify if data values are outside that range. So you may have maybe someone's 201, and that may be valid, but at least you'll get a message that says, hey, are you sure this is correct? So the system is checking as you go along. And, in addition to that, I don't have it documented here, but REDCap in particular has tools to run over your data after data entry to look for missing values and outliers and that kind of thing. So then we have a third stage that we use where we have a data auditor who goes and checks our records. You might not necessarily look at every single field, especially when you have a data set where you're collecting 2,000 variables. But over time, you determine which variables are problematic and seem to have errors. And so you can check those. And that person will generate queries that will be sent back to the research associate who entered the data in the system. They'll resolve those queries and kind of do that in a circular process until everything is correct. And then the case is ready to go. And then really kind of a stage 4 approach here is between our data quality and our data analysis process. And Tim's going to talk about data analysis here in a minute. So we have kind of a bridge here. Because we're embedded in a clinical group, we have a lot of experience doing this, and we kind of understand how the research process works. So when Tim and his staff go to do their analysis, they're not just going to start the analysis, they're also going to check data quality. They're going to look for missing values and outliers and run through several things. Hopefully we will have caught most problems by the time he gets the data, but if not, then his team will actually go through the process of trying to figure out how to fix any data errors that we find. Of course, one of the critical problems of missing data, or of data collection, is missing data. Actually, we have developed a tool called our completeness grid generator that lets us actually look at data sets to determine where we have missing data. And we can look at specific records, or we can look at the entire data set as a whole. And in fact, we just had a publication accepted in Journal of Biomedical Informatics on this tool that we wrote. So now that we looked at the data management, I'll pass it back over to Tim, and he can talk about the data analysis that we can do.
This is fun stuff. Everyone knows biostats. So, and our staff in the support unit, we have not just significant experience, but statistically significant experience. We usually like to use confidence intervals to show our statistical significance, but you can rest assured the p-value is very small. So when you come to us, we're going to talk about kind of what tier of analysis you need. You need just basic biostatistics, chi-squared, t-test, these types of things. You need more advanced biostatistical stuff like multivariable regression, propensity scoring, instrumental variables. Do you need to map stuff? Or do you really need a bioinformatics approach? Do you need machine learning, data mining, these types of analyses? We can do all of this. So I'm going to go through a couple of projects we've worked on recently just to prove that I'm not lying. So with Jim Graham in the Department of Microbiology, actually got one of 2 Gates Foundation awards ever in the state of Kentucky and the only one ever at the University of Louisville.
So this project was focused on developing a breath test to diagnose tuberculosis. So any organism that's growing in the lung has different metabolism, and you might expect, this was a hypothesis, that your exhaled breath is going to have different volatile organic compounds in it. So with the help of Sean Fu in the chemical engineering department, they developed a microchip that collects all these VOCs from your breath. You blow on it, they run it through a mass spec, and then they send me this big data set of a bunch of numbers and a bunch of VOCs. And say, here, develop an algorithm to help us diagnose tuberculosis. So here we used a bunch of more high-level informatics approaches, machine learning, support vector machines, random forests, as well as, and that was all to kind of develop this algorithm to narrow down the amount of data that we actually needed to most accurately predict tuberculosis. And then we used some traditional techniques of diagnostic accuracy to figure out if this algorithm was actually effective or not. Unfortunately, I can't show you the results yet because Jim probably not published yet. So with Jose Bordone, the physician at Providence Hospital in Washington, D.C., we've been working with him for a number of years, but we published a paper in Chess relatively recently looking at the long-term impact of having community-acquired pneumonia. So is it just, the acute pneumonia that's bad for you that might decrease your ability to survive, or is it really something that's going to impact you long-term? So here we had 10,000 patients from the VA here, administrative data, and 1,000 of them had community-acquired pneumonia. The other 9,000 were admitted to the medical ward for some other reason. So obviously these patients are very different, and we had to come up with a method of adjusting for all the bias that's inherent in patients that are way different than each other. So we were able to develop a new severity assessment tool modifying the already present one, the Charleston Comorbidity Index, which you may have heard of. So we used some survival analysis techniques, some multivariable models, to prove that on the left, the Kaplan-Meier curve, you can see that over the course of 7 years, if you have community-acquired pneumonia, you have a significantly increased chance of dying compared to anyone who hasn't had it. Our good buddy Rodrigo Cavalazzi, I don't know if Rodrigo's here today, but we've been working with him a lot lately. He came to us saying, CDC has all these criteria for predicting patients if a patient has tuberculosis or not. Well, I don't think that they really predict tuberculosis in a patient with pneumonia. So let's take a look at it. So we did that and found that, of course, the CDC criteria were pretty terrible at predicting the presence of tuberculosis in a hospitalized patient with community-acquired pneumonia. So using some severity score development tools, multivariable modeling again, receiver operating characteristic curves, we're able to come up with a new prediction tool to diagnose tuberculosis in hospitalized patients with pneumonia. And you can see here in the RLC curve on the right, our new CAPO TB risk score was significantly better at predicting tuberculosis. In the very early days of the support unit, one of the fellows from trauma surgery came with a very specific question related to their mushroom extract and immune modulation. It's kind of an interesting study. I wanted some of the mushroom extract myself, but so we published this in the Journal of Trauma and Acute Care Surgery. But really what you needed was to look for outliers. So there's a lot of different methods to look for outliers in your data set, but you had a very specific and unique question. So we actually had to do a fair amount of research to figure out that, this test, I had never actually heard of it at the time, the Moses test of extreme reactions would be the best test to answer their question. Now, this Moses guy was super busy with his 10 Commandments and his statistical testing. So Carmen Shortino, if you haven't worked with Carmen over at the VA, he's a great guy, the chief of microbiology. We have all of these adenosine triphosphate bioluminescent monitors now for infection control reasons. So, ATP is kind of the molecule of life, so, everyone has it, everything has it that's living, and if you're on a surface, you're going to spit out ATP on the surface. So these monitors wipe up the ATP and measure it. So it's a kind of a proxy for microbial contamination on the surface. So there's a bunch of different machines, obviously, since it's an expensive technology. So we wanted to see if one machine was better than the other, if they were actually valid. So we were validating a bunch of machines, and so Carmen came to us with all these data saying, it looks like it's all over the place. How do we make sense of these data that are all over the place? So we used some traditional statistical techniques, ANOVA, some regression modeling, and he came up with this wonderful, I call it a spaghetti chart, which looks like
get a junction from the air. Anthony Torres in Barcelona, Spain. So this is one we're kind of proud of because Anthony has a huge clinical research operation, probably one of the biggest in Europe. Huge staff, way bigger than ours, and he still came to us for our expertise, particularly in this propensity scoring methodology. So propensity scores are a method of developing a tool to better adjust for confounding bias, particularly for observation studies. And actually, if you do it right, there's literature to suggest that well-matched or well-adjusted observational study using a propensity score mimics a randomized control trial just as well as the randomization. So we were looking at the impact of steroids on ICU-acquired pneumonia, and we found that you can see the propensity-adjusted curve down here at the bottom. There wasn't really any significant impact of steroid use on the 28-day mortality in these patients, but increasing dosage of the steroids actually seemed to trend towards worse outcomes. Published in Critical Care Medicine. Stefano Alberti, University of Milan, is actually a research associate with us a number of years ago, moved back to Italy and became a faculty member at his university. He was interested in defining how we define clinical stability in a hospitalized patient with pneumonia. So Dr. Ramirez, back in the day, developed the original criteria for clinical stability. So those were used in the guidelines, the ATS guidelines in 2001. And then later on, other people have developed other criteria. Well, the other criteria are much more complicated to compute. So we always want to use the simplest approach. So we compared the Ramirez criteria with the home criteria in 2007 and found that really there's no difference. They're the same at predicting clinical stability in these patients. So here we used a lot of survival analysis as well as ROC curves. So you see kind of a trend towards, we use the same types of things over and over again. It's very common in clinical research. We use the same tools. But in general, the term's the same, but the model building and the other things are the difficult piece of the analysis. So just last week, we published this study looking at, with Nathan Dean in Utah, looking at predicting outcomes in patients with aspiration pneumonia. And this was kind of an interesting study because aspiration is really a clinical definition other than something that you really can just clearly extract badly from the medical record. So we had to deal with a lot of different confounding issues because, this is an international database and different physicians are going to say this is aspiration, this isn't aspiration, and, it also is different country to country. So over the course of about a year, we worked on this analysis back and forth using pretty much everything imaginable. And we ended up with a very unique scheme, I think, for this particular study where we used a multivariable matching algorithm. We were able to match a patient with aspiration to a patient without aspiration on over 20 clinical variables. So I think we balanced out the confounding quite well. With Dr. Saad here, pulmonary, we've done a lot of quality improvement studies over the years. This one was published in the Journal of Intensive Care Medicine, looking at the impact of some of their procedural and educational interventions for reduction of BAP and CLABSIs in the ICU. So at the time, they had all these data, and everyone was using just regular rates and stuff to compare, rate of BAP year to year. So at the time, the CDC was developing this technique called the standardized infection ratio. It wasn't really being used, but it seemed exciting, so we decided to go ahead and try to use it for this study. And we did, and found that Dr. Saad's interventions were very effective at reducing these infections. So since then, the CDC has actually become quite fond of the SIR and made it mandatory for all facilities to use the standardized infection ratio for mandatory reporting of all healthcare-associated infections. Kentucky's not a mandatory reporting state, so we don't use it too much here. Rob's worked a lot with Janet and Tina in the diabetes management program here at UofL to show that their program is effective at stabilizing patients' A1C levels. So recently, these two studies were presented at a local endocrinology meeting, and it goes to show that we don't always have to do propensity matched and all kinds of crazy stuff. We just need to do the statistical test that answers the question that we need. So I mentioned this study before in quality improvement over at Kindred. We're looking at different techniques to reduce organisms in the environment, especially C. diff, because C. diff spores are really hard to kill.
So we had a pretty large outbreak of C. diff over at Kindred a while back, and we decided to institute a quality improvement study where we had 2 interventions. The first one was using a diluted disinfectant that would kill the C. diff spores. So we started using this. You can see the rate dropped a little bit. But we went back and reevaluated the process and found that there were a lot of issues with environmental services and how they were diluting the disinfectant and how they were using it. So we went to a 1-step disinfectant that further reduced the rate of C. diff and stabilized it over time. So this technique, this chart, you can see a little bit of the lines here on the figure here. So this is a statistical process control chart. Very pervasive in the quality literature, but not so much in the medical literature. You can see every now and then someone uses this for a quality study. But this allows us to really rapidly detect differences in anything as long as you're collecting data, time series over time. Statistical process control charts are great to figure out if there's some abnormal variation happening. Of course, I have to mention the stuff that we're doing in ID. You name it, we've probably done it. Right now, we're focused on a lot of geospatial and geotemporal analyses with help of Brian Quinn here from our team. Since we're collecting data from all hospitalized patients with lower respiratory tract infections in all 9 adult hospitals in Jefferson County, we have incidence data. So this map is broken up by census tract. So our denominator for our rate then is just the population, since almost all of the people in Jefferson County go to these hospitals. So this particular map is looking at the risk of hospitalization with lower respiratory tract infection based on your home proximity to a known toxic release site that's EPA registered here in Jefferson County. So back over to Rob to talk about scientific writing.
All right, so we'll finish up here with kind of letting you know what we can do to help you with various types of scientific writing. As many of you know, some of the main types that we work with, of course, are abstracts for conferences that eventually get moved to posters or possibly presentations. Of course, the main thing that we're trying to go for with our research is to get manuscripts, and then down the road, use the basis of our research to get more grants so that we can do more research and write more manuscripts, and so on and so forth. So we can assist you with preparing your abstracts for conferences. We have some templates that we've used that have been very successful. We've had a lot of abstracts over the years accepted. We can also help you move that abstract to a poster or an oral presentation if you're going to be presented that way. In fact, with our posters, we can possibly, there we go, thank you, we can actually print that for you. We have a poster printer in the division that go to so many conferences, so we can take care of that for you for a nominal fee. In addition, we can help you with structuring your manuscript or grant through templates that we've developed over the years. And we can even help you with writing and editing consultations. Sometimes we'll actually get together in our conference room and work on manuscripts, as a group and kind of work through it that way. So we can help with that if you need it. And finally, we can help you with assist you with submitting your manuscript to your journal. Doing these submissions actually can take quite a bit of time, a lot longer than people realize. So actually, we've got somebody in the division, Kim Buckner, who we just turn that over to, and she takes care of it for us. And we can do that for you as well. So that kind of gives you an idea of the types of publication work that we can help you with. Big question, of course, is a lot of people want to know, how much is this going to cost me? Well, right now it's free. Unless you're funded already, in which case we would like to get a piece of that. Really, what we're trying to do is recoup our costs down the road with future funding. So in other words, we'd like to be involved in your grants, to be the data coordinating center for grants that you submit, so we'd be supported that way. And obviously, the only way to kind of get you to that point is for free, so that you can get those grants and you can be funded. So that's really our major goal there. Our team, as you know, Dr. Ramirez, of course, is the director of the CTRSU. Ruth Carrico and Paul Ferrani are also both assistant directors of the CTRSU. And then some of our other team members, we have Bill Mattingly, postdoctoral associate from CECS, who helps a lot with building our tools that we use. Brian Gwynn and Laura Binford are both MPH candidates, working with epidemiology and biostats. Kim Buckner, I mentioned earlier, is the manager of CTRSU. She kind of makes sure that we all stay on track. Matt Grassman does IT support for us and does a little programming. And then James Summersgill and Wada on the Ely work with our biorepository. So, if you want to do a biorepository project, they'll help you with that. If you ever want to contact us, here's our number, and we have an email address, CTRSU@louisville.edu. And I would like to thank Dr. Ramirez, or Tim and I would like to thank Dr. Ramirez and Dr. Roman for giving us the opportunity to present to you today and to let you know what we can do. Thanks a lot.
Before I turn this to questions, just a couple of comments. Number one is to put this into perspective. We just did the numbers this week about clinical trials. This department alone has a number of clinical trials that if all the patients included in these trials that were projected to be recruited for these trials were actually recruited, we will bring in close to $40 million. $40 million in industry-sponsored and other sponsored clinical trials. That is more than the double of my clinical revenue. That is double of the NIH funding that we have. So clinical trials is an important part of what we do because that's how we generate knowledge. But economically, because people are worried about cost these days, it's a big deal for this department. The institution brings $45 million. 40 come from this department. This is important to us. The second point I want to make is that just this year, I was sitting at the VA with a fellow who had not a busy day. So we just had a consult in the morning, we're sitting around, and I said, you're not leaving this week without a project, because we're not going to be sitting around. And he's now doing a sleep fellowship. He said, how about we do something about sleep? He developed a hypothesis, we wrote it up in a couple of days, and then he said, well, but I need sample size, and we need statistical analysis, and I said, go to these guys, El Kirsch, who might be here today. Go to these guys, and he put it up together, he submitted to the IRB, he got it approved, he's already got 20 patients recruited. This is all in a period of less than 6 months. To engage in clinical research, all you have to be as a clinician, all you have to have is some passion and where to know where to go. So if you're a clinician and have some passion for discovery, you today have learned where to go. So questions? Questions? Yes?
So most of the studies that you showed were mostly hospital data that I noticed, or maybe the outpatient clinics. But we have a large amount of potential with the patients that we see at the HCOC and ACB. But as you may be aware, Allscripts doesn't have the potential or is not ready for prime time, I guess. So how do you go about that?
That process is going to be very similar to what we do in the hospitals. I mean, literally, I'd have somebody abstract some data from Allscripts onto a paper CRF, and then you would enter it into your study database. But we can help you with that if you want to try that.
But I'm told by the Allscripts IT, I mean, I don't know if Dr. Kubiak is here, correct me if I'm wrong, that they're not ready to do the clinical research part of it. Just like I do at the VA, I'm able to get data out of CTRS, and we have done a lot of fellow-based abstracts and everything, and I didn't know if that's possible with that.
As far as we're aware, the system is not ready for that, and it's something that we're looking at constantly as well, because with our HIV students, we want to do the same thing.
I think it's not like the VA where you can call somebody and say, can you pull all these diabetic patients from 2007 to 2008? That's true.
Once you get the IRB.
That's true. But if someone in your group does have access to Allscripts, they can define a way how to screen the data. It's not going to be as easy yet, but you're absolutely correct. But that doesn't mean the question shouldn't be answered. And you may have to look for other ways to access it. And that's where they can do it. So you're correct that every system, because the electronic systems are different and they're in different stage of evolution, they may not be as easy to work with than others. But the question still needs addressing. Questions?
How do you work with, or is there overlap with OCRSS, and what's the relationship?
Why don't you explain what OCRSS is?
So OCRSS is the Office of Clinical Research Services and Support. OCRSS is, from our standpoint, we use them a lot for the regulatory piece, as well as like grant submissions and that kind of thing. So they're really good with regulatory stuff and budgets and submissions. So we do the data collection analysis, more of the rubber to the road science, and they're more interested in the administrative and business side.
Do you do anything with research nurses and patient enrollment like they do?
Well, we have research associates in our group, but typically we don't have associates for projects that are not originating in IP at this time.
So based on the number of contracts that I've had to sign for people that Julio is recruiting, they must have like an army of research coordinators. But at this stage, he's correct, that coordinators they have are for the studies trying to address people in everywhere in Kentucky. But so there may be support for developing the pre-award project. OCRSS engages in implementation and financial administration and so forth. And then if you have resources, then research coordinators can be recruited. But at this stage, this is somewhat fragmented, no question about it. I will tell you that the pulmonary group, which we started here with Ronnie Foles and I and others, was very engaged in doing these on our own, and we have slowly been moving all of our trials to OCRSS as well. And they're very helpful, extremely helpful. Questions? Comments? So I want the students and the residents to think about this, but I also want the clinical faculty to think about the following. If doing rounds, if while sitting around looking at a case, if while at clinic, if at home, you're not considering how to answer a clinical question through a project, you're missing an incredible opportunity. Anybody can be a doctor these days. There are over 140 medical schools throughout the United States. There are thousands of students coming out as physicians every day, in and out. The work that they do for those patients is crucial, but will never change unless somebody in academia begins to move that pendulum into understanding things in a very more sophisticated way. That can come from very simple projects, retrospective cohorts, just getting simple data. I often tell people in the ICU that the best advances in critical care in the past 2 decades have not been about a ventilator, have not been about a new antibiotic, have not been about the swine, which is not even used anymore. It's been about logistics. Somebody decided to study whether doing a list of outcomes in the ICU was better than not doing it at all. Somebody just decided to look if waking patients up in the morning was better than keeping them asleep on the ventilator. And all that data has changed dramatically the way we manage patients in the critical care unit. It happens in every entity. But somebody has to come with a question. Somebody has the passion. And now you have the resources. Have a good day.
Of course. Yeah. I got
Yeah.
We already have it. They fill in and give us one. We'll do the basic science and say, here's
All right, I'll see you later.
I'll see ya.
When do you guys think you'll be back in the office?
That was my
I'd be surprised how hard I've got.